Okay, friends and colleagues, if I could draw your attention. So as indicated, I'm David Cohen. I'm a member of the board here. I'm in my 40th year at UNSW. I wouldn't have it any other way. It's at the moment the best university in the country and moving up the rankings. So thanks very much for choosing UNSW to do your degrees. So how many of you are doing graduate studies here? Put your hand up. That means you're no longer an undergraduate, for those confused. Okay. Masters, PhDs. Okay, for the rest of you, how many are doing degrees in medicine or medical sciences? Put your hand up. Okay, I've been watching. You will be the first people I will point to ask some questions of our speaker at the end. So again, welcome to tonight's proceedings. Unfortunately, the Master couldn't be here. He's in Narendra. I have no idea why he's in Narendra, but he is, so I'm standing in for him. What a wonderful tradition in universities to have illustrious people come and speak to us over dinner, especially if they are alumni of New College. And of course that's the benefit we have tonight with Professor Kelvin Kong AM, who will be addressing us on various issues. Kelvin is a professor and a practitioner and a surgeon in paediatric and adult otorhinolaryngology. Okay, and that's the only time I'm going to say that word. It's taken me some time. In the good old days, we referred to them as ear, nose and throat people because those are words I can pronounce. And I did have an uncle who was in that area of medicine. Kelvin feels incredibly fortunate to having led and continuing to lead a very fulfilling life surrounded by his loved ones with a demonstrated and eminent history of service in the health industry. Brings a wealth of expertise across various sectors including clinical research, medical education, surgery, paediatrics, health policy and Indigenous education. Kelvin started his university residing at this college in '92, so it's a fairly recent acquisition to the university, which brings him very fond memories of his time at the university. And of course medicine has continued to expand here, and since your time we've now taken over all the land between the university and the hospital for various medical research institutes, so medicine continues to be in the ascendancy here as it should be. Graduating from medicine here, Kelvin continued his studies and became a fellow of the Royal Australian College of Surgeons and the Australian Society of that long word with Greek and Latin base, and also Head and Neck Society. It's based in Newcastle on Awabakal and Worimi country. Kelvin specialises in those areas indicated. Practice encompasses a diverse range of adult and paediatric patients. Particular interest in paediatric airways and cochlear implants. And of course this university has had a close relationship with cochlear for many years. Been a very fruitful relationship. Beyond his clinical work, Kelvin is deeply committed to community service, which is something we would hope of all graduates at this university. His dedication to improving health outcomes extend to his role as a prof at the University of Newcastle School of Medicine and Public Health. And of course at one point Newcastle was a college of UNSW, as was Wollongong before they became independent universities. He's also holding honorary professorships at Macquarie University and here. He's the senior examiner of the ORL Mini Court for the Royal Australian College of Surgeons and a member of the National Ear and Hearing Health Partnership Committee, just to highlight a few. He hails from the Warramai people of Port Stephens in New South Wales, and Kelvin's heritage informs his passion for health and education improvement initiatives. He remains grounded in the support of his family and which continue to inspire him in his efforts to give back to the community. So through his advocacy, research, clinical practice, Kelvin strives to make a positive impact on the lives of others, guided by his commitment to equity and the well-being of all. So a beautiful example of a UNSW graduate. And at this juncture, I would ask Kelvin to come and address us.
Thank you for the lovely introduction. I hope I don't disappoint after that introduction. After such a warm welcome, it's really a pleasure to be here. Wibu nata yete Kelvin Kong, nara manam gure, waramagaba baragaba. I want to start by thanking for the wonderful welcome. I want to also acknowledge the welcome to the country, acknowledgement of country at the start, and also to state that I have been lucky enough to work and play and have benefited greatly from the greater Eora Nation and many Aboriginal people who have had a lot of involuntary sacrifice for the amazing flourishment of this university. And I do want to pay my respect to those elders, to those living, and to any Aboriginal people here this evening. It's a real pleasure to be walking back on these grounds, and I think it just started flooding my memory. I wish I came here beforehand, because I think I could have told a lot more stories as I walk in. It just, you suddenly remember a lot of other things. But it's quite nostalgic to walk back in here and feel so proud and so privileged to be able to walk into these colleges again. But I want to reflect on the reality of when I walked in the first time. And when I first came to university here, I was terrified. I was scared. I had no idea what Sydney was about. I had no idea about what university was about. And so to have that kind of weird feeling walking in here now floods those memories of both good and bad, of fear, of excitement, and of a career which I hope I can inspire you guys too. When Ward said, what should I talk about? When I asked him, he kind of said, talk about what you want to talk about some of the memories, talk about some of the things that's going on there. But I think I want to try and peel it back a little bit. And I have too many stories to tell, I don't want to bore you guys, but also want to be able to reflect and show you guys some things and hopefully make you guys think about where your careers are heading and what you're doing, and also the benefit and privilege we have of being here. And on that note, I want to thank the board for inviting me. I want to especially thank the Master, Bill, who's unfortunately not here, and I feel dreadful not being here, but I've never actually had an email from him like this, where he's actually apologised for not being here tonight in advance, and I think that's really shows a humility to me, but also a respect for you guys and how much he values being amongst such an important dinner for you guys. So thank you to the board, thank you to the people who invited me here tonight, and thank you for everyone coming tonight. So to understand me, I guess you want to understand a little bit about my origins, and I want to take you through just 2 episodes of my life, that's it. And I'll wander on for a little bit because I tend to meander a little bit. But the first one is going back to when I was a 10-year-old boy. And to understand what I was going through at that time, it was really a time where I did not feel very comfortable about myself. And where I hope you can reflect on this is that I was growing up in a small town as an Aboriginal and Chinese boy. And I hated them both. And I actually believed the racism that endured me. And I came home from school one day after being teased all day, not knowing who I was, not knowing where I am, not really understanding what was happening with me. And my mum caught me in the bath, scrubbing my skin where it was red raw, trying to wash off my Aboriginality, trying to cleanse out my Chinese heritage. And at that point in my life, I just couldn't be consoled on why I was in a world that didn't actually want me in it. And I didn't understand why the subtle things that people say hurt me so badly. And I want to go back to that 10-year-old boy now and just pat him on the back and say, it's okay, it doesn't matter. Things work out for a reason. And so I think from that early stage where you start getting some of those things, and all of us have experienced it in this room, of the displeasure of some of the things that are afforded to you, but also of the things that you're teased about, and also the role in which you think you don't fit in our strange society. And it really plays a role in wanting to give back and think about that young person. And when people ask why I give back from that, is I go back to look back at myself and my family and my cousins and think about what would have made a difference to me. And I think that's how I treat this and how I treat this evening. And so when I was asked to come here, and what you probably don't realise is this dinner here tonight is about 2, maybe 3 years in the making. It's because New College kept saying, please come down, please come down. I said, I'm really sorry, I'm busy, I'm really sorry, I'm busy. No worries, please come down, please come down. And it got to this stage where we booked tonight's dinner 12 months ago to make sure I could come, so I had no excuse to come down here. Hence why I got the email from Bill saying, I am so sorry I've mixed the dates up, can we change? I said, I'd love to, but I can't because of my schedule. He said, nah, you're coming down, I'll just miss it and we'll talk later time. So I do promise in front of you also, he can hold me accountable for this. I'll come down when he's back. We just need to make the time to make sure that's there. But in understanding that then is, I guess, fast forwarding now to a month ago where I was just doing something which was a lot of fun. And so I want to take you through 6 hours of my life now where it actually changes all those perspectives of what I had in there. And the other month I was on call and I got a phone call at 3 a.m. in the morning. I'm not on call for the hospital, but I get called by the hospital saying, you need to come in the hospital now. Here's the picture, you got a picture. I've got 3 kids, 10, 9 and 6. My 2 daughters in bed with my wife and I. One daughter's foot was on my face. Another daughter's on my leg. And when the phone rang, she whacked me in the head and said, turn it off, Dad, I'm trying to sleep. Then when I wake up trying to get the phone, there's all this drool on my face from her, trying to answer the phone and see what's going on. The hospital needed an emergency because there's a baby being born and I needed to help. So of course the first question is, you're an ENT surgeon, why are you going to help deliver a baby? What I'm called in for is for a procedure called an exit procedure. Now I know most people in here aren't medical, so I'll go through the basics, but it's also fun because I think it also emphasises how amazing our health industry is in Australia, but also how strong our public health system is, which is why I'm such a strong advocate for, which is why anyone who's involved in the health system needs to support as much as possible. I deliberately didn't do photos tonight because I've got great photos of these operations, but I didn't want to scare you too much from that. But it really is a representation of some of the things we get up to, but how much fun it is, and I apologise for that because I'm a bit sick with that aspect, but how much fun it is to do these amazing things with the body at different ages that you can get away with, and it's really cool to see that. And it's a collision of all these emotions all in the one, of fear, of adrenaline, of excitement, of a new life, of a passing life. But an incredible human spirit, all of us coming together to try and make this work well. So what is an exit procedure? To understand exit procedure, you need to understand pregnancy. And you guys are way too young to understand that, so I'll have to talk to you about it. When you have a baby, the things that happens once the baby's developed is when you go into labour, certain stages happen. You contract, which means your baby's ready to come out. Then when the baby comes out, you contract hard, so the placenta, which is your lifeline, sheds off the uterus, and the baby comes out and starts this new world. And that all happens pretty spontaneously, or relatively quickly from when it comes out. And that can be quite fast and quite scary. Now the reason why I was called in for this baby is because it was an emergency operation because this baby had a tumour in its mouth. And I was only found out, again from our wonderful technology that we have, that you actually see this in utero when the mum was actually getting bigger and bigger, but the baby wasn't growing. And so as part of when you're growing, you're swallowing the fluid, which makes you grow. But at the same time, if you can't swallow it, then the fluid just fills up in your belly. And so the mum had an ultrasound done. They couldn't find the baby because there's so much fluid in the belly. And this is at 29 weeks. And so they got an MRI scan to see what was going on with the baby. And the baby was there, but it was tiny. The baby was about the size of my fist. Tiny little thing. But what you could see on the MRI scan is that it had a big tumour in its mouth. Now, normally what would happen with these babies is these babies would be born, there'd be a stillbirth because they'd come out and it wouldn't be able to breathe because it had an obstruction in its mouth, and therefore everything would be lost very quickly. But because of the way in which we are, we can now start planning to see if we can actually do something for this baby. So this mother presented to a regional hospital in Australia at 28 weeks with this large tummy. Accumulating the food was going on there. When they were transferred to our hospital, we thought we better get them down here just in case something happened, but we need to start planning for this procedure. So transferred to the hospital so we can actually see what's going on. I got called on Monday during the day to say, look, this mum's come down, there's a tumour in her mouth, we need your help. We're going to have a meeting tomorrow to make sure we plan for this and get it right. We're going to get the MRI scan done, we'll get an ultrasound done, we'll get the fluid out so we can see the baby better, and we'll make a plan for it. I said, great, let's do that. That was Tuesday. So what happens Monday night? This is my 3 o'clock call in the morning. It's happened early. We don't have time to have this meeting. We've got to get moving. And so I rushed into the operating theatre to see what we could do to try and help this out. So what an exit procedure is that what you can do is you can actually run some of the anaesthetic through the mum that goes to the baby. Because the baby comes out, it's too small, it's too tiny, you can't get IV access, you can't get a tube in, and the baby passes away. And so what we want to try and do is reverse some of that physiology so we can run all the anaesthetic through the mum, so through the placenta the baby's anaesthetised, and therefore do what we need to do. The second thing we don't want happening is the uterus to contract, because if the uterus contracts, the baby pops out and we've got nothing and we're stuck with nothing again. And so with research, and again talking to these guys before, research dictates what we can try and do. We know that if we use certain anaesthetics, we can slow down that placenta contraction for at least 60 minutes from the time the baby comes out. But there's a catch to it. You can only deliver the head and one shoulder. That's it. And so you do a caesarean section, which is a cut in the tummy, and all you do is pull the head out and one arm, which gives you an arm to try and put some monitors on. You've got the head out, which we can operate on, and you actually get an ultrasound on the baby's heart to make sure the baby's good. But the mum still is anaesthetised, and the baby's anaesthetised through the placenta. But as soon as that first incision is made, the clock ticks for how much time you've got before this baby's delivered and passes away. And so in my normal operating theatre, we have about 6 people in the theatre. An anaesthetist, their assistant, myself, maybe an assistant and a nurse. In this theatre, we have about 35 people. And the reason you need so many people is you need an anaesthetist for the mum, an assistant for the anaesthetist for that. You need an anaesthetist for the baby. You need a neonatologist or intensive care paediatrician for the baby. You need a humidicrib for the baby. You need midwives for the baby. You need the obstetrician, their assistants. You need the ENT team and MAO team. You need our scrub sisters for me. You need the scrub sisters for the obstetrician. You need the scrub sisters for the neonatologist. And of course, you've got 3 or 4 med students running around going, what is happening here? And so I go into hospital, and by the time I get there, it's about 3:15. And so it's one of the weirdest things to do because you meet the father and mum for the first time, and the conversation you have to have with him is very, very hard because you don't know what's going to happen. You're going to try your best to do what you can do, but you're not sure of the outcome. And so here's a consent saying, I'm here to try and help your baby. I don't know what's going on with your baby. We've got no, I have not seen the scans. I've not seen anyone. I've just come in here because this has all happened very quickly. The mum's kind of in tune to it, but it's one of those weird anaesthetics where she's going to go to sleep and she doesn't know whether she's going to wake up. She doesn't know whether her baby's going to wake up. And her dad doesn't even know what's going on. And it's one of those really, really precarious situations and a very emotional situation whilst you're trying to stay calm at the same time as trying to organise theatres. And so while all this is happening, with preparation starts happening and things take time to organise such a huge assembly. And what makes it worse then is you're trying to organise a team at 3:30 in the morning. Most hospitals realise how busy it is those kind of times. But of course tonight, what do you think's happened? There was a car crash on the freeways, there's a neurotrauma coming in, and there's also a transplant happening, and there's also been a pub fight, and so there's a couple of guys that have been slashed, and so they're now operating as well. And so we have one theatre open, but we have 4 operations that need to occur. And so not only are we then dealing with the emotions of the family, I'm starting to deal with the emotions of the in-charge in hospital saying, you've got to call more people in. We can't have one theatre, we need 4 theatres, we need this happening now. At the same time then, you're trying to get staff in, but you can't just get any old staff in. Staff need to be there who know what they're doing in this kind of weird situation. And it's certainly weird when you're dealing with such a weird operation, but add in the complexities of not knowing what we're actually going to be delivering, what we need to do to fix this. At the same time of having 4 traumas in, we probably need quite a lot of blood ourselves with the bleeding that we're going to encounter. And so this is this chaos of symphony that we have. And it's so nice to hear the beautiful band. Thank you very much. It is like a symphony of getting everyone humming the same song, playing the same song and doing the same thing, so it actually works in harmony. And it's easy to say it's a rugby crowd, but you've got everyone doing their special thing, where the ball goes in the scrum comes out, the ball comes out, you pass on, and this baby's like a football, it's going to get passed along from the obstetrician to myself, to the neonatologist, to the humidity crib, and then to the ICU, in all those kind of steps. And if you don't get this step right, things happen bad. Simple things like transferring the baby from the womb, if we do deliver it, to the humidity crib is a matter of 2 metres. Can't be close to that because of all the stuff that's in the road. But this is a slippery baby who weighs 1.1 kilos. Easily can drop. So we get there. We've got all these people in the room. We've got everyone happening in the room, and things start happening out. The timeout in this procedure is probably one of the most detailed ones we get because we've got to make sure everyone's in the right place. And we begin the C-section. And once you make that first incision, everyone's got to be quiet. You could hear a pin drop in these 35 people in the room because things are starting to happen, things are getting real in that space. What's nice for me in this scenario is that baby's actually breached, which means it's actually the wrong way around, but that actually gives me more room because normally I've got to be standing around the hip, whereas I could actually stand up towards the top of the belly. The head pops out and you see there's a small little head there with a big tumour in the mouth, and the tumour's probably about the size of a plum, but the baby's head's not much bigger. We were lucky enough then, so then it's passed over to me, trying to operate whilst the baby's in the womb, with the obstetricians and that there, with bleeding happening around for where they made the incisions because it's a quick delivery. But we managed to actually somehow get around this tumour, secure the airway. Once the airway is secured, the lungs are moving, the baby's alive, it goes from being blue to a pink colour, pull the rest of the baby out. So whilst I'm holding the head, securing the airway, the obstetricians then deliver the rest of the baby and pull the baby out, and then we deal with the placenta cord, actually reverse and get back to the normal physiology that's meant to happen. Then passing the baby on, we then work out whether we need to leave the tube in there or we need to deal with the tumour straight away. Luckily for us at this time, we could actually pass the baby on, get the baby resuscitated, and this baby in a humidity crib, being 1.1 kilos, you can imagine what it looks like. It's like you're operating on a baby rabbit. It is so, so tiny. It is cute, but very, very small and very frightening. Of all this happening from that point of view, the tension in the room's huge, but once you get the tube in there and the bunch of babies resuscitated and the mum's still alive, everyone just breathes and you just see the tension just relax and suddenly it gets all noisy in the room again. And it was quite weird to see that because once everything's all relaxed and everything's all happening and you see things around you because you're so focused on this one thing happening, you've actually realised that you brought a life into this world. I'll come back to that in a second. Because in all this chaos, and you can imagine the amount of chaos that was happening in this scenario, is that in the glimpse of the corner of my eye when I finally looked up, in the anaesthetic bay, all the excitement happening, we forgot to take the dad out of the operating room. So he's in the corner crying, not knowing what's going on, and I just looked at him and said, "Your baby's alive." And he just cried more. And I started having tears in my eye then because then I could actually relax a little bit. And I just went over and gave him the biggest hug, not realising I'm still in scrubs with blood all over me. He didn't care, it was his baby's blood, so I was all fine from that perspective. But the emotions in that, and to see that, and for him to witness that, was just incredible amount of emotions that went in that room. But we were lucky on that scenario, and we're lucky we got through that. The scenario I'm describing is a scenario of hope, because if we could diagnose that, and now go to the geneticists, and also the ethical dilemma of if this baby was not to survive, how would that look with such an event going on? Are we doing it just for fun? Are we doing it for the wrong reasons? What's going to happen to this baby? If I go back a step and we diagnose at a time to think about it and work out whether we should or should not revive this baby, then is that the right thing to do? Are we making a decision for the parents when we don't know? Is it too hard basket and his baby wouldn't have survived? This baby's now alive and thriving. I did one like this 6 years ago. And for those who see me on social media, I posted a photo with this kid who was 6 years old and starting school and reading and writing and was just the most delightful kid. Same kind of scenario, but 6 years earlier. And again, when I saw him 6 years later, it just brought so much joy to me, because this is a thing that we talk about, whether we do the right thing by making these babies survive. It's a huge cost to the society and for us. But to see a baby thrive like that and do so well is incredible. And we practice in an era of medico-legal stability at the moment, which makes it quite hard to do that. But what is the cost of life? And what is the cost of us being here? So now I want to go back to what we mean by that. And that's so important, because we are all here and we're all doing well and we've all been on our different journeys. And so now I go back to that 10-year-old me after doing such a procedure. I'd love to go back and go, one day you're going to do some fun stuff. This is the hump you're going in, and this is a little blip in your life. And although at the time when I was 10, I thought it was the end of the world for me, in reality that was just the beginning of my determination, of my drive, of my belief. But that's not my journey. The journey that I have has been because of my family, which is why I'm so eternally grateful for them, and how nice it was to be thanked for my family to let me be here tonight. They share my time. My kids would text me on the way down here chatting to me, wanting to come down, and I do drag them down to some things. But it goes back to that unfamiliar territory of walking to this room where I was terrified, not knowing what was going to happen again, whether I'm recycling those 10-year-old boy emotions of, am I in the wrong place? And some of us in our classes, when you get difficult classes, will think, am I actually in the wrong place? You'll have imposter syndrome where you think, I don't deserve to be here. You'll have amazing moments where you think, yeah, I deserve to be here. You have all those things in between where you're not sure where you're going and not sure what's going on. You'll have the racism that will cop on you. You'll have the sexism that will cop on top of you. You have all these other issues that are going to come up as a barrier for you, as a challenge for you. And rather than think of those issues as something that you should take on board and think negativity about, it's something you should absorb and say, this is going to make me tougher. I don't believe that. Have belief in yourself. The final part of that is obviously then how New College, the university community, and your bigger family play a role in that. New College took a bit of a risk in taking me on board. The university took a bit of risk of me coming on board. But there were plenty of believers that said, you know what, in the right environment, things are going to happen really well. And I'm a testament to that belief, of that community wanting to drive to make this world a better place. And for that, I'm indebted to New College. For that, I'm indebted to the university. And I hope that the community get the benefit of all that education I've been lucky enough to afford. And so I'll leave you this final thought then, and that is all everyone around you, your friends you meet in New College, your friends you meet at university, the friends you meet in your career. They're the heartbeat in your hardest days. They're the ones that actually need to be there for you when you're struggling. But on a similar note, when you see someone else struggling, you need to be that heartbeat for them, to pick them up, to say it's going to be okay. Wrap them up when they feel unworthy, so they feel worthy. And know that their presence, know that they're not walking alone in this journey, because our journey is a huge journey. Every soul we come across, every new person we meet, every new opportunity we get to meet other people is an opportunity to gain strength on yourself, but to help others out. So reach out, listen to each other, look after each other. And certainly in this kind of climate, in this world we live in at the moment, more so, rather than actually fill the world with hate, we need to pull those closer together and love more and make people realise how much everyone means to us, rather than push people away to make ourselves feel better. And it's not just the kindness that we're doing it for. It is our duty. So you can look at that 10-year-old version of you and know that someone's going to cuddle that 10-year-old version of you, and you're the first person to do that when you're here right now. Because when we truly help other people, we can love ourselves and be more productive for society. Thanks for listening, guys.
So if Kelvin's willing, we'll take a few questions. A microphone will be circling. So, first volunteer for a question.
Oh, every day. I think I'm stronger now than I was then, obviously, and so I have a way of dealing with it in a way which is with compassion. I think in my teenage years I was very angry and probably said things I probably shouldn't have, and so I think you get maturity around you. But I think where the real strength came from for me, and what I realise now, is not me rebutting some of those calls. It's my colleagues around me saying, "Hang on, we don't say that anymore. We don't do that anymore. This is what we've got to do from there." A simple example, when I did during COVID, so COVID was all locked down in the hospitals, and I'm in and out of the hospital all kinds of hours. And I came in at 1 o'clock in the morning and one night for an airway emergency for a trauma case, and I was pulled up by security and I was questioned going, "You can't just walk in here, it's COVID. You need to make sure that it's limited because we're spreading COVID, blah, 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 blah. Have you got your ID?" And 1 o'clock in the morning, I'm just so used to coming in and out, it didn't worry me at all. And so I had to go back to the car, try and find my ID and come back. And yet, when I walked into theatres, not one of the other people in that theatre were asked for ID. Not one of those people in that theatre were asked to stop in security. They just walked through. And so that security guard based their decision on me in my board shorts and shirt. I know I look pretty terrible that kind of time of morning. There was an assumption that was made on that. And so, rather than getting angry at that kind of scenario, I was then getting some education around security staff about how we're going to get rid of that bias that happens from that point of view. And bias still happens in every part of our day, and you'll see that happen more and more so. But I think it's the way in which you actually deal with that and internalise it and actually make something productive of it rather than being challenging from that point of view. And I think we all get that in every part of what we see. I'm not here to. There's so many examples I'll give now, but all of you know those, and whether there's scenarios you want to throw in my face and see how I'd respond differently, I'm happy to. But there's certainly things that happen to this day. Good question, though. Excellent question. Ear, nose and throat surgery is the best, especially by far, isn't that obvious answer? I think I was saying before, is the people you come across are the people that you fall in love with what they do, inspires you. And I had a lot of wonderful mentors. And when I was a student here, I was with a surgeon who did ENT, and Peter Carter was his name, and he did airway surgery, did community work, he did a lot of ear work in the communities, he took me out to some of the remote communities and did work, and so I could relate to it from that point of view, but also the fact that he did all these really fascinating, cool things just made me really enjoy that, so I followed that passion from there. But I was saying to these guys earlier on is that, and honestly, I don't think you get to choose your profession. I think your profession will end up choosing you. And you'll start finding things you like and you don't like, and you'll just naturally gravitate to those that you aspire to. But the only caution of wind there is that when there's minorities in surgery, in females, then you need to actually step up and say, you know, I actually like this, and find the females there. So there's a couple of females I mentor who want to do surgery, and I ring around and find out where the female-friendly surgical departments are and push them that way to get there. And once they get there, they just go when they're doing amazing things. So find the right people around you, you'll find your passion. But also find a passion you love, because if you find a passion you love, I don't care getting up at 3 o'clock in the morning going in because it's fun.
Thank you, Prof. Kong. Can you hear? Can everyone hear? Sorry, I always have to check. So you mentioned a little bit about how our experiences and tough times kind of like shape our life and how we like view things in retrospect as well. I find that perspective really insightful. In terms of being a pediatrician, a lot of children go through like life-changing events like early on. As a pediatrician, how do you kind of like shape that and kind of empower children as they grow older with these experiences that we've had?
I think it's really important to show kids love. It's really important to show kids positivity, and I don't think they need to see or hear a lot of negativity that they unfortunately endure. In kids I look after who are unwell, you got to look for the fun things for them. The one thing they're brilliant at, and I'd love to do a research project on it, is they should become the navigators of the healthcare system, because the healthcare system is really hard and they just know it inside out. They know it better than I do, some of these kids. And so you need to find what their strengths are and push that forward, but also their humility and their enjoyment in life reflects. And I love working with kids because of that. You know, I had a kid that I fixed their ears on, and he kept going back to the toilet and flushing. I'm, Mum, come and listen to the waterfall. And he'd never heard the toilet flush before, like such a simple thing that we take for granted that he was actually finding enjoyment in. And so I think you need to find that enjoyment in there, but also relate to them. You see, and I think as doctors we're probably overrepresented in neurodiversity, and so when we're talking to these kids, sometimes we can't really relate. You've got to sit down with them, get on the ground with them, yarn to them, and just spend that extra bit of time with them so they actually trust you, and you get some great stories from kids. So again, if you don't have that inclination, you'll end up as a radiologist. That's okay. You'll find your passion. Sorry, radiologists. Just a joke, just a joke.
Thank you so much for your speech, Professor Kong. I am also a medical student, and I was just wondering, you come across as someone who's very family oriented. How are you able to juggle being in such a demanding career that takes so much of your time and energy, and yet still be a really present parent to your children?
It's not easy, and it's taken me a long time to try and get a good balance. And I think I've got a good balance now, but if my wife was standing next to me, she'd say I've got a terrible balance. And my kids would probably say somewhere between those two. I think I judge it on the way in which I mentor. So when I was going through trying to get into surgery and do things, it was a case of, if you want to do surgery, you have to do. And I think some of the hard conversations now, which I hate having, and I don't have a place to have the conversations, is talking to my junior female colleagues who are aspiring to be surgeons, and they ask about family, and I think I have the wrong answer, because my answer is, you have family first, you have your kids, you do whatever you want to do, and if surgery comes along, great, surgery comes along. If it doesn't, don't come along. Whereas the advice that was in the old days would be, don't have babies till you finish surgery, and then you're 102 when you finish surgery, you can have kids now, and you're like, hang on, I've missed the whole chance. I think we're designed to have family, and we're designed to enjoy family. And so I try and prioritise that for us. So for me as a boss, that means I've got to make that for my trainees. I kick them out of the hospital at 5:30. I don't like them hanging around if they don't need to hang around. If there's something interesting going on, I give it to their choice. You hang, you're welcome to. You don't want to, that's okay. and also making sure that they have that life balance. So in my assessments of my trainees, I don't just ask them about all the medical stuff. I say, what are you doing with your family? What are you doing with your partner? What are you doing to keep yourself active? What are you doing for the community? They're the questions that are pertinent to me. And so I think if I put importance on it to them, then they'll start shaping their careers around some of that. I had one of my female trainees who wanted to do ENT, and she really wanted to have a family. She goes, oh, I've been told not to have family. I said, go and have your kid. She had a kid, then she got into surgery. She got in first year surgery, she's had another kid, and she's loving life, and the balance is perfect. And she's so, so happy, and I think we need to have more of those conversations. Yeah, that's not saying you have to have kids. If you choose not to, that's okay. Well, that's your choice. It's not my choice for that. And you'll find out again what your balance is in and around for some of that. You know, one of the most abhorrent kind of questions I have is, should I freeze eggs so I can do surgery? And I think, well, don't even ask that. That's not even a question for that. For medical reasons, absolutely, if you need to, that's okay. But I don't think we should be putting our careers on hold for family. But again, I'm very family-minded. I always put family first from that perspective. I try and finish, and the reason I kick my registrars out, because I want to go home. And so, you know, I try and get home at 5:30, and I'll do reading time with the kids and hang out with the kids, and then at 7:30, 8 o'clock when they're down, I'll do some of my research work and papers and emails, stuff like that. So I just juggle things around to do that, to make sure that I have that time with them, which I love.
Can I ask a follow-up question? Do you think it's realistic to be having children during internship and residency? Because it's very common that the work is invested in taking up a lot of your time.
I think you've got to make plans for what you want to make plans for. I don't believe that. Life's tough. No matter what you do, life's tough. And so you need to make sure that you can manage that in a way that's also appropriate for your children. So if you're going to have children as an intern, then, you know, I would consider part-time training. Now, part-time internship, part-time residency is quite acceptable now. 10 years ago, don't even ask. Certainly in surgery, 5 years ago, don't even ask. But now, people are planning, saying, look, I want to have kids in my JMO 2 year, and then I want to get in surgery in my 4th year, and they plan it beautifully, and I really like that. There is no rush to get through your training. Once you get to the end, you become very, very busy. So it's nice to actually take that journey on there. Now, I'm just one view. There's all obviously very different views there, but no, I think don't wait for those kind of things to let them happen. I think they should happen naturally. Pleasure.
Thank you very much for your talk. I was just wondering,